Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
In this video, we are covering respiratory pharmacology. We are covering a wide variety of drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. First, we will address medications that treat airflow disorders, such as asthma and COPD. Before we begin diving in fully, I want to provide some general NCLEX tips when approaching answering questions about respiratory disorders or diseases. Remember your ABCs when it comes to nursing prioritization. Establish a clear, patent airway first, whether that is through positioning or administration of a medication that opens the airway. Next, focus on breathing, such as through the application of oxygen and medications that can help normalize work of breathing. Then, focus on circulation to help fill in the entire clinical picture. Okay, now let's begin for real. Starting off, we have our short-acting beta agonists, aka our SABAs. These are the first-line medications to provide rapid relief in acute exacerbations where the airway is compromised. Albuterol helps to restore the airway by reducing bronchospasm and decreasing histamine activity. However, as a beta agonist, the heart rate may increase and patients may exhibit tachycardia, tremors, and agitation due to increased systemic stimulation. While this is expected, be sure to monitor for indications of a compromised cardiac output, such as reports of shortness of breath and chest pain. When treating acute exacerbations, this rapid-acting rescue drug should be used first in order to open the airway to allow for other inhaled medications to reach the site of action. Our NCLEX nugget is to keep the acronym AIM in mind when thinking about our response to asthma attacks. Albuterol, then ipratropium, then methylprednisolone. Speaking of ipratropium, let's talk about this inhaled anticholinergic next. This drug acts to dilate and relax the airways, likewise utilizing its anticholinergic effects to decrease mucus production to achieve greater airway patency. This is not a rescue medication in of itself, but is used in the AIM acronym as a secondary treatment during acute asthma exacerbations. It is indicated for symptom control in chronic airway diseases such as COPD. Being an anticholinergic drug, expect anticholinergic side effects. Can't see, can't pee, can't spit, can't shh. Patient education should emphasize increasing fiber and fluids, chewing sugarless gum, and utilizing eye lubricants to treat these side effects. Adverse effects to watch for include dizziness, epistaxis, and headache. Theophylline is a medication indicated for control of asthma, COPD, and other chronic respiratory conditions. It provides systemic stimulation, relaxing the smooth muscles of the respiratory tract. However, this medication does have a narrow therapeutic range of 5 to 15 micrograms per milliliter, and toxicity may result in GI distress and restlessness that can progress to dysrhythmias and seizures. Toxicity may occur through improper dosing, but also when this medication is combined with caffeine-containing food and drink, such as sodas, chocolate, and coffee. To treat toxicity, start with least invasive methods first, such as activated charcoal. IV lidocaine may be utilized in the treatment of cardiac dysrhythmias, and IV lorazepam may be necessary to control seizure activity. Onto our glucocorticoids, the third leg of the AIM acronym. These medications do not provide rapid relief, but are able to target and reduce inflammation to facilitate condition improvement in the response to acute exacerbations, as well as symptom management and prevention of exacerbations in long-term treatment. However, since long-term use and high doses of steroids can lead to adverse effects, long-term use should be avoided if at all possible, and dosing should be monitored closely by the provider. When discontinuing these medications, care should be taken to taper the dose, and alternate day dosing may be indicated to prevent severe withdrawal symptoms. Complications of steroid use include hyperglycemia, immunosuppression, and increased risk of infection, delayed wound healing, and electrolyte imbalances, such as hypokalemia and hypernatremia. Steroids should be taken with food and in divided doses, and patients should be instructed to monitor for indications of GI bleeding, avoiding NSAIDs to reduce the risk of ulceration. Cromolyn is a mast cell stabilizer, which is indicated for prevention and treatment of rhinitis, seasonal allergies, and exercise-induced bronchospasm. This medication being used for long-term control should be taken on a schedule rather than PRN. Potential side effects include anticholinergic effects and impaired immune response. Our final drug in this category are leukotriene modifiers, such as montelukast. Inflammation and bronchoconstriction are reduced with this medication, making it useful in the treatment of chronic allergies and exercise-induced bronchospasm. When used for EIB, make sure patients know to take only once per 24-hour period, and at least 2 hours prior to exercise. The greatest risk of leukotriene modifiers is hepatic hepatic toxicity, and so patients' liver function tests should be monitored frequently. Avoid concurrent alcohol consumption and concurrent use of other hepatotoxic medications. Next up are medications that can be used to treat allergies and sensitivity reactions. First, we will address our sedating antihistamines, including diphenhydramine and promethazine. These medications may be indicated for the treatment of emesis, motion sickness, insomnia, and may also be used to reduce acute anxiety and agitation in some instances. IV administration of these medications requires special attention. For both of these medications, dilute and push slowly to avoid rebound overstimulation, excitability, and anxiety. Promethazine is highly vesicant and should only be given in a large patent vein, such as in the AC or more proximal. Side effects include sedation, anticholinergic effects, and paradoxical excitation, such as if pushed too fast, as previously mentioned. Non-sedating antihistamines include cetirizine and loratadine. These medications do not cross the blood-brain barrier, thereby conferring less CNS effects, such as central depression. These medications are likewise indicated for rhinitis and urticaria. While sedation is not commonly seen with these medications, patients should still exhibit caution and restrain from engaging in high-alert activities until the effects of these medications are known. Anticholinergic effects should prompt patient teaching, such as increasing fiber and fluids, and limiting use with concurrent conditions such as urinary retention. Phenylephrine and pseudoephedrine are sympathomimetic drugs, helping to treat symptoms of common colds, rhinitis, and sinusitis. As the sympathetic nervous system is activated, vasoconstriction in the nasal passages can alleviate excessive mucus drainage and promote airway patency. However, this also means that side effects of hypertension and tachycardia may occur as well. Monitor the patient for indications of dysrhythmias and avoid concurrent administration with other vasoactive medications. Doing so may compromise perfusion and lead to ischemic events. Coughs can be irksome and last a long time after the period of illness is concluded, so let's be sure to cover some medications that can be used in managing cough. Codeine with dextromethorphan is an antitussive medication, functioning as an opioid to suppress the cough reflex in the CNS. As such, it is highly effective in providing relief from chronic and severe coughing. But being an opioid, there are some important teaching elements to consider. Use should be limited due to there being a high potential for abuse. Other CNS depressants should not be combined with this medication, or else severe CNS and respiratory depression can occur. Like other opioid medications, increase fluids and fiber to encourage motility, and do not use this medication prior to engaging in high alert activity. Naloxone may be indicated to reverse the effects of this medication should overdose occur. Guaifenesin is an expectorant medication, meaning it is utilized to help promote the expelling of sputum. The surface tension of secretions is reduced, therefore thinning the viscosity so that secretions can be coughed more effectively. Surface tension thinning requires adequate fluid intake, so patients should be instructed to take this medication with adequate water. Do not combine with medications such as antitussives that suppress the cough reflex. Otherwise, the patient may be put at risk for aspirating their thin secretions if they cannot be expelled. Expected side effects include GI upset, dizziness, and drowsiness. The final medication to be covered is acetylcysteine, a mucolytic medication which breaks down the proteins in sputum to reduce viscosity. This makes it useful in treating bronchopulmonary conditions such as cystic fibrosis, but also indicates it for the off-label use of acetaminophen overdose. Patient education should set expectations for this medication. The gaseous form has a sulfuric, rotten egg smell, and it may trigger emesis. Pre-medicating with antiemetics such as Zofran may be indicated for patients with sensitive stomachs. Since this medication breaks protein down, if given through any sort of tubing such as through IV lines, make sure to flush with saline or change the tubing afterwards. As secretions are thinned, aspiration risk increases, especially for patients who have difficulty coughing effectively. Be sure to prepare and be ready to use suctioning equipment to help clear the airway. Thank you for watching this quick review of respiratory drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.